Hello, we are going to be talking about skin conditions. This is still under Unit 1, covered in the book chapters 20 and 21. So there's a couple different diseases we're going to be talking about and going there. So first one is dryness, pruritus, and urticaria. Dryness, we know what it is, dry skin. Pruritus, fancy medical term for itching. And urticaria, fancy medical term for hives. The reason we're talking about all three of these together is they often come together and are caused or cause each other. So you usually see all three together. Not always, but sometimes. Again, causes and risk factors. This could be dry climate, could cause eye dryness, poor lubrication of skin, or dehydration. Pruritus could be reaction to allergies, dry skin, medication side effects. Uh, we might have maybe the first indication of systemic diseases such as diabetes, cancer, kidney problems. Our urticaria is usually going to be our allergic reaction or hives. It can also be a reaction to certain medications such as antibiotics or NSAIDs. We might see it with severe infections, insect bites. It can also happen with stress or contact with chemical. But again, we have that overlap between the three. Our clinical manifestations, we want to be able to identify it and we want to be able to correctly identify it. That way we can correctly teach it. Dryness, we're going to have scaling, flaking. Pruritus is going to be a verbal report of itching. Urticaria, we're going to have those raised bumps. Uh, Wheals are going to be fluid filled uh, raised bumps. They'll also have a pale halo around the bottom. Again, this helps us differentiate between hives and, let's say, chickenpox or pimples. We want to be able to differentiate. It's going to blanch with pressure, and it's also usually associated with severe itching. So our treatment, once we know what the problem is, we can fix it. So dryness, we're going to put on lotion or some sort of lubrication to help hold on to that fluid. A really good thing is to do this after a shower or after a bath when the skin's still moist. It's going to be better able to absorb it. We might have humidifiers in the room. We might put humidifiers on oxygen if they're having that, educate them and increase fluid. A lot of times your patients will non-consciously be drinking soda, tea, or coffee, which is diuretics, which can dry you out. Pruritus, we want to identify the cause and fix it. And depending on what's going on, we can do our antipyretic agents. Maybe that's an allergy med or Benadryl. We can do corticosteroids because, again, you can't have itching if you don't have an immune system. Because, again, if it's being caused by an autoimmune or immune disorder, that's going to stop the inflammation uh, itching part. We can do oral antihistamines. And these could be topical or oral. We can also do ultraviolet light. We'll talk about that when we start talking about our cirrhosis, because cirrhosis tends to cause extreme itching. Urticaria, a lot of it's going to be dependent on how bad it is. And our highest priority for urticaria is going to be, are they having anaphylaxis? Are they having trouble breathing? Because we're going to see an allergic reaction and anaphylaxis is going to start up the very same. If it's an allergic reaction, we're going to give them antihistamines. We're going to figure out what's going on. We're going to monitor them. We might give them some Benadryl. We might give them some calamine lotion. That. If they got anaphylaxis, we're doing epinephrine. We're doing steroids. We're probably going to do an EpiPen because, again, ABCs, airway breathing circulation. If you can't breathe, you dead. So, how do we determine if it's allergic reaction or anaphylaxis? I want you to take a moment, pause the video, and think about how we could differentiate. So, main thing is we're going to be looking at the neck and throat. Can they talk? Are they having trouble swallowing? Are they reporting difficulty breathing? Anything that's messing around here is going to tell us that that is going to be more anaphylaxis, and we're going to do our steroids, epinephrine. If it's more of an allergic reaction, We're going to do our antihistamines, and depending on how bad it is, we might do steroids. But that's that big thing. We need to assess and figure out which one it is. Because one is, that sucks. And one is, ooh, we call it a code. So we have to be able to differentiate that. Skin patch test is going to be an allergy test. We're going to figure out exactly what you're allergic to. Another thing we can do is having a journal and having them note when they're having those signs of itchiness. And a lot of times urticaria and our pruritus could be any number of things. It could be a new lotion, new detergent. It could be pollen. It could be bee stings, peanut butter. The other thing to keep in mind for allergies is they tend to get worse. So we're going to want to. So nursing diagnoses, and all of these could be relevant for our dryness, pruritus or urticaria, impaired skin integrity, acute pain, risk for infection, knowledge deficit. So we talked about in previous class recordings how we would prioritize that. So again, whenever we talk about prioritization, we want to think about Maslow's. You can also do ABCs, but that's not always as accurate. And if you haven't yet, make sure you have your lovely Maslow's triangle set up. So this has just got off the internet, and this is our Maslow's hierarchy of needs. We have our physical needs, which is the very bottom. This is usually what we think of for ABCs: airway, breathing, circulation. Food, water, warmth, rest. Pain is also there, but pain is the least important. Then we have safety above that, and this is safe walking, mobility. Do you have a safe place to live, a roof over your head, enough money to pay the rent? And then we have love and belonging. This is someone's got to care about you. You have that sense of belonging, that sense of community, friendship, maybe it's partnership. But again, you have someone, something that cares about you. Then we have self-esteem. Patient has to like them. They have to have that feeling of accomplishment, that feeling of purpose, and being able to do that. A lot of times our spiritual problems would fall under our esteem or love and belonging, depending on, we can kind of do that. The very last one is self-actualization. And this is where our actively trying to learn something new, trying to grow, all of our education is going to be there. So we want to kind of do that. So let's go ahead and go back, and we're going to look at our. So for here, again, you can Google and pull up one of the Maslow's. I want you to think about what order we would put these in. Pause, talk about it, and then we'll go. All right, so I'm going to say acute pain is going to be highest priority because it's physiological. Even though it's the least important and no one's died from pain, it is still that physiological need. Second is going to be our impaired skin integrity. This is going to be our safety. We're worried about things. Then for our self-actualization is going to be our knowledge deficit. And the last is going to be risk for infection. Again, risk for is almost always the least priority. The only exception, I think, is risk for suicide, because that is a safety thing, because there's always exceptions. Nursing's never black and white. But this is how I would prioritize those four nursing diagnoses. All right, so now we have our physical assessment. We got to figure out, where are you itching? Are you itching anywhere outside? Has it spread? Is it moving? When did it start? And again, we want to figure out, why are you having itching, dryness, and urticaria? Is it an underlying disease like cirrhosis? Is it an allergic reaction? Is it due to a chemical reaction? Again, we got to figure out what's going on. We got to assess. Because once we know what it is, if we remove that irritant, it should go away, right? So if you're allergic to peanut butter, avoid all peanut butter, and you should not have itching and urticaria, right? Understandable. We also want to, with this, educate our patients. We are going to educate them about their medications. For example, if they're going to be taking Benadryl, it's going to cause dizziness and drowsiness. Should not be taking it with alcohol. The steroids, if we're given that, is going to help, but it's also going to stop their immune system. So they're going to be at greater risk for infection. Also, remember, steroids can cause you to hold on to water, gain weight. We don't want them to stop taking it suddenly. Um, we want to make sure they know what we're doing. What is the skin patch test going to take? How long does the EpiPen work? Do they know how to use the EpiPen? We want to make sure they know how to treat dryness, pruritus, urticaria, and know when to come to the doctor or to the ER when it's getting worse. They need to be able to know, for example, the difference between an allergic reaction and anaphylaxis. Because again, one is a that sucks to me, and the other one is, oh no, we're going to call a rapid, we're going to call a code. Keeping up with follow-up appointments, we want them to follow up with the doctor, make sure those meds we're giving them is actually working, and again, knowing when to notify the doctor. All right, so next disease we're going to talk about is psoriasis. And there is a video you can watch on your own PowerPoint if you so choose. Oh. So, psoriasis is a chronic scaling disorder. I have the chapters and pages up here, so you can either follow along or look at that. It is an autoimmune reaction. So, your immune system is attacking your skin cells. Again, since it's autoimmune, severe patients will actually have where it goes from attacking the skin cells to actually attacking the bones, and you can have psoriatic arthritis. There's three types of psoriasis. Psoriasis vulgaris, which is a really mean way to just say ugly, because vulgar, ugly, and it comes from the Latin term. So this is the most common type. Usually it's a notable scaling. We have a lovely picture here. And a lot of times, the biggest issues with psoriasis is going to be our self-esteem, our belonging. They look different. People will kind of double take or be hesitant to touch them or come in contact. And that can cause self-esteem, mental issues, as well as other anxiety things. Exfoliative psoriasis is going to have where we have that exfoliation. So they're constantly shedding. We're constantly having almost like dandruff coming off them. And palmoplantar psoriasis is going to be affecting the palms and the bottom of their feet. Um, there is no known cure. So let's think about it. If we are having psoriasis and we know this is caused by autoimmune, what do we think we're going to do to fix it? We can't fix the disease, but we can manage the symptoms. And again, if the problem is autoimmune, we're going to just turn off the immune system. Woo! Yeah. We could also remove the plaques, and this will temporarily reduce the visual effects because, again, we talked about the main issues are usually self-esteem and belonging. So we want to be able to differentiate and to identify. We have what's called red flag symptoms, and I have these on my PowerPoints here. And these are going to be your cues, your specific symptoms that tell it it's this disease versus another. I like to use the red flag because it helps differentiate it. Because when we start talking about all the skin conditions, we're going to see a lot of them overlap. And being able to differentiate it is important. Because again, if you don't know what the problem is, you can't fix it. So we're going to have our pruritus or itching. We're going to have silvery white scales. They're going to be raised, hard. We're also going to have those papules. Most commonly, it's on the scalp, the elbows, the knees, the lower back, buttocks, and sacrum. They can also have yellow, discolored, pitted nails. And again, we talked about it's autoimmune, so eventually they can have joint inflammation and deformity. Again, we have elevated red and plaques, and it's usually silvery white. Uh, Most commonly, it affects our Caucasians, our pasty white people. Uh, we do have different colored and other ethnicities, but that is very, very rarely. So almost every picture in your book and online is going to be showing that silvery white, because again, it's usually present on our Caucasians. So it's autoimmune. So if we stop the immune system, we will not have the problems. But if they have no immune system, now we got those other problems. So we can do steroids. because immune system is pretty much an on-off switch. We're going to turn it off, but that comes with all the side effects, so we want to educate. The other ones down here are just going to be reducing the um, size and coloration of that. And these are all going to be temporary measures because eventually the immune system is going to attack and build up. Because as the immune system attacks, the skin does what it can to try to be resistant and it builds these thick plaques. So, tar preparation, think about if you've ever heard history, tar and feather. We're going to put this thick, liquid, messy chemical on there and whip it off, kind of like you're waxing. And we're going to remove the top layer of skin. It doesn't tend to be painful because remember, the top layer of your skin is dead. But these tend to can cause permanent staining to your clothing and your healthy skin. They tend to have an unpleasant odor. It is present as ointment, lotion, gels, and shampoos to remove and irritate it. The only good thing is it's really, really cheap. It's been around, I think, for over 100 years. Your book doesn't say specifically, but it has been around for quite a while. We have our anthrin. This is going to be a temporary solution. It is going to relieve that chronic psoriasis. It is a strong irritant, so we do not want to put it on healthy skin because it can actually cause chemical burns. But it is going to dissolve or liquefy a lot of those scaly plaques, removing it and making it look more like healthy skin. Again, until the immune system starts attacking it and the skin builds up, because again, it is temporary. Our retinol derivatives are giving vitamin A or vitamin D, and this causes the skin to be much, much more hypersensitive. It's usually used with corticosteroids to increase the likelihood of using that, making them more likely to fall off and be less visible. Be aware that they are tetragenic. It can cause severe birth defects. So with that, don't want to use it if you want to become pregnant or are pregnant. Also, we don't want, the pregnant wife putting it on their partner's plaques because again, it can absorb into there. So that's a safety thing. But it is very useful to make the skin cells more hypersensitive and more reactive to what other medications we're giving them. Our emollients are going to be salicylic acid, and they're usually used along with other medications to soften the skin, to help with that itchiness and that dryness. Um, Again, we want to look into, we usually only do steroids, and if we start having severe symptoms like our arthritis and our other symptoms, usually we're going to do tar or anthraline with our retinoid or emollients to reduce the severity and the visual look. Because again, we talked about that love and belonging, that sense of self, that sense of belonging. That's going to usually be our highest priority. If that doesn't work, we can also go a little bit up. We talked about for our itching, you can do UV light. So that's our phototherapy. UV light is very useful. We're going to pretty much kill off the cells by using that ultraviolet light. Our photochemotherapy, very similar. We're going to use it. They can also use that to treat skin cells. But if we're shoving UV light on our patient, who's most likely a pasty white person, what am I worried about? Skin cancer. Absolutely. So that can be useful, and we'll usually go to a clinic or something like that where they'll have a specific phototherapy. We don't want them to go into a tanning bed because, again, even though it's UV light, we want it to be directed and controlled. And we will usually also give them some of those medications, such as our Amprolin, I'm sorry, such as our retinoids, or we could be using a cream. We do want to be careful because, again, a lot of these medications, like our retinoids, are going to make you more hypersensitive. So there are higher risk for burns and high risk for skin cancer. We can also do our systemic, our corticosteroids. Because again, you can't have an autoimmune disease if you don't have an immune system. We can also do our cytotoxic preparations, and our cytotoxic is literally just going to be killing off the cells. This is on table, yeah, methotrexate, cyclosporin. They can be toxic, so we want to be monitoring liver and our bone marrow status. But we're going to kill off the cells. And if we kill off the cells, ooh, they don't look ugly anymore. Yay! Until they grow back. We can also do our biological agents. These are on table 21.6. So make sure you review those. There's, I believe, four of them. Our adalimumab, our etanercept, our infliximab, and our secukinumab. Oh, there's five, sorry. And ustekinumab. I probably butchered those so horribly. Um, but there's one or two sentences in your book that talks about the big, big safety things. A lot of these are going to be our biological things. So we are going to be worried about compromised immunity. Because similar to our corticosteroids, these are going to turn off or mitigate the ability of your immune system to work. And you can't have an autoimmune disease if you don't have an immune system. But now you have an altered or ineffective immune system, so we're worried about don't be around sick people. You can't get active live vaccines. You're more likely to get opportunistic infections. So we want to make sure to teach about that. Some of those also have latex, so we're worried about latex allergies. So again, make sure you know those different diseases because um, that's one of the drugs you probably, unlike steroids, don't get to use all the time. So psoriasis can occur at any age. Usually median onset is going to be about 28. It's most prevalent in obese white female Caucasians. And again, if we have a darker toned individual that has psoriasis, it doesn't tend to be um, white or silvery. Your book does not describe what it would be like, just that it would be different in a darker skin tone person. So make sure you know that. All right, so our we got this is a video you can watch on your own that is talking about the actual medications and how we'd administer them. Patient teaching. Uh, Verbalized concerns. We want to know what is important to them. Usually, the most common problem or reported concern is that isolation, that sense of not belonging. Um, I know I've seen some of the commercials on TV before where they're wearing long sleeve shirts all the time and scared to go out in public because people are going to stare at them, point. We want them to apply those medications properly. We don't want the steroids or the other agents to be on healthy skin because it can cause irritants. We want to make sure they're wearing gloves when they're applying it or when their spouse is applying it. We don't want them to scratch because now we're going to have an open wound on top of that. We monitor skin. Stress is going to make it worse. Using warm water can help soften it. We don't want hot because it can cause burn. Using emollients, make sure we're going to follow-up appointments. We're worried about skin cancer because again, we tend to have our Caucasian white individuals that have it, and they're taking medications that makes their skin more sensitive. They also need to be able to notify the doctor. Are they showing signs of infection? Are they showing signs of the psoriasis getting worse and affecting their bones or their joints? Are they seeing signs of skin cancer, which we will talk about later? They need to know when to report, what not to report. All right, speaking of, we get to talk about skin cancer. So, skin cancer, this is the only cancer we're going to be talking about for the whole of 242. So, for the rest of the test, if you come across anything that says liver cancer or lung cancer, that is not a 242 problem. That might be a future problem, but you can kind of skip over it. But there are three types of skin cancer: basal cell carcinoma, squamous cell carcinoma, and melanoma. And we know cancer is where the cells are so focused on just reproducing, they don't do the job. And when enough of those cells don't do their job, you got tissue failure, organ failure, and then eventually death. So, all three of these are skin cells. And if you think back to anatomy and physiology, the basal, squamous, and melanoma are in different levels of the skin. since it is all skin cancer, they're all going to be caused by the same thing. UV exposure, prolonged sun exposure, or some kind of carcinogenic, such as radiation. Sunbathing, tanning beds, UV lights. We just talked about treatment for psoriasis could be UV radiation. And again, the most likely people to get it is going to be our pasty white people. Because again, they don't tend to have as much melanin, more likely to burn. We do know our other ethnicities can have it, but they tend to be more on the paler sides of their bodies, and we'll talk about that. So, our squamous cell tends to be in the dermis, basal is slightly below that, and our melanocytes is the melanin part, the deepest part of our skin. So again, we want to be able to know what they look like so we can treat it. Squamous cells lie just below the outer surface, and they function as the new baby skin cells. Our basal cells sit below the squamous cell, and our melanocytes are in the lower part of the epidermis. So I got red flag again, so you can kind of differentiate and know them. Usually, we learn about our ABCs, A, B, C, D, E. This is because melanoma, even though it is the least common, is the most deadly. So that's usually the one we hear about. But we have distinctly different symptoms. So our basal cell, which is over here, is going to have pearly or waxy bumps. Telangiectasias is the fancy way to say like the spider veins. You can also see sometimes what's called like pigment flecks on there. They tend to also have a bleeding or scabbing sore that does not heal properly. Squamous cell, which is over here, is going to be a flat lesion with a scaly crusted surface. This is actually the most common cause of lip cancer. So having it around the lip, because that's usually a squamous cell. It's also a firm red nodule is another one. Melanoma is usually going to be a mole or a freckle that has changed color, has changed sizes, or bleeds, and we'll talk about it a little bit. We usually have the acronym ABCDE to differentiate. But we want to know what it is. Squamous cell and basal cell tend to be much, much less life-threatening, but much more important. We want them to be able to know it is skin cancer so we can get it tested and we can start them on medication and treatment. And we know our treatment, you don't need to memorize any of the specific drugs, chemotherapy, radiation, our UV therapy. Just know about the general things. We're going to be focused on pain management, monitoring for signs and symptoms of either worsening skin cancer or infection, because a lot of these medications are going to compromise their immunity, monitoring for nausea, vomiting, anxiety, depression. We're going to be giving medications. They're probably going to need prolonged IV access. We want to prevent future incidences, so lots of teaching. We want them to be wearing, the big sun hat, long sleeve shirts during the daytime, sunscreen all the time, even if they're just driving. Because, fun fact, we have found that people tend to have a skin cancer on the left side of their face because they just get slammed with light as they're driving to and from work. We should be wearing lotion and sunscreen all the time, especially if you're like me and you're a pasty white person. So we already talked about most likely going to help with our pale Irish, Scottish, Celtic ancestry, red or blonde hair, fair skin. Melanoma tends to affect women more than men, usually under 40. And squamous cell, we talked about very common for lip cancer. That's also the one that can occur. So we want to be able to look in darker skin. We'll usually look at the palms or the lighter parts of their body. So for patient teaching, we talked about our ABCDE. A stands for asymmetry. You have a mole or a freckle is not equal one left and right side. That is not a normal thing, so that could be a sign. B is border, a spot that has an irregular border or poorly defined. C is color. A spot that has changed color or is two different colors can again be a sign. D is diameter. Usually, skin cancer is greater than 6 millimeters or about the size of a pencil eraser. And E is evolving, a spot that has changed color, size, or shape. Uh, this is only for melanoma, though. Remember, this will not be helpful or relevant for squamous cell or basal cell carcinoma. For all three, we want to teach them sun prevention, when to wear sunscreen, what kind of sunscreen to wear. Make sure if you're outside, you're wearing long sleeves and, our lovely sun hats. Make sure that they're not tanning or having UV radiation. Be aware of meds that increase photosensitivity, which could be our retinoids we talked about for psoriasis or other medications. Make sure they're taking the medications to treat skin cancer and being aware and monitoring it. All right, so now we have our next disease we're going to talk about, which is our cellulitis. So our cellulitis is an infection appearing in the dermis or subcutaneous tissue. Most commonly is caused by Staphylococcus, or Streptococci, both of which are normal bacteria that live on the surface of our skin. And somehow they get underneath the skin and they just go crazy because it's the best environment ever. This can occur from any opening in the skin. This could be a scratch, this could be a puncture, this could be a dog bite, anything that allows the surface bacteria to enter underneath the skin. IV therapy, venous insufficiency, diabetes are much more likely. Edema, insect bites. Our patients who have immunosuppression, again, are high risk because they're going to be at risk for opportunistic infection. And of course, our lack of asepsis when we're talking about invasive procedures, which could be inserting a Foley catheter, it could be surgery, it could be a biopsy bedside. Either way, that lack of asepsis is a risk factor. So we have our red flag symptoms, and we have what's called three different things. We have localized. So localized is going to be in one area, such as in our picture here, we have the bottom of the foot. That would be our localized. We have redness or erythema, edema, pain, swelling. Sometimes we'll also have weeping. Systemic, this is our sepsis. This is going to be entire body. So we went for the foot and now we're having those systemic symptoms, that infection. We're going to have the lymph nodes start affecting fever, diaphoresis, and pyrexia. And you might be like, well, what is pyrexia? Fancy medical term for fever. Regional would be a region. So we went from the foot to the entire lower leg. That would be regional. Systemic might be the entire leg from the foot all the way up to the hip. So we have those distinctions. The symptoms are going to be slightly different. Again, I want to be able to recognize it as cellulitis so we can treat it. What's the first thing we got to do? We got to figure out what is causing it so we can kill it. So again, wound culture sensitivity. We're going to do white blood cell count. Figure out, do we have the elevated white blood cell? What kind is it? Because again, if it's neutrophils, it's going to be bacteria. If it's eosinophil, parasitic. And we want to make sure this isn't just an allergic reaction or something like that. Again, very, very important. We have to get the wound culture before we start on antibiotics because otherwise it will not be accurate. We want to do our assessment. We want to figure out, when did this redness start? We're going to draw a lovely border to make sure it's not spreading. Most cellulitis is treated outpatient with oral or topical antibiotics. We're going to monitor it, but it depends on the location and severity. We might need to do IV antibiotics, and if that's the case, they're going to be admitted to the hospital. We're going to do warm, moist compresses, which will help vasodilate the blood vessels and help with that swelling and edema. We also want to elevate because, again, that's going to be our friends to help pull that fluid off. This is a pet peeve of mine. When we talk about elevate, it should be lower than their heart, higher than their heart. I've had more than one patient that they are sitting and their foot is just here. That does not do anything. It needs to be higher. Because I've had people put it up on footstools. So I'm like, that doesn't work. It's got to be higher than your heart. But again, all of these are going to help us know what's going on. Cellulitis can occur at any age, but of course, our patients who are elderly or have some sort of vascular insufficiency are greater risk. And again, redness and inflammation is not always super noticeable. For me, I'm a pasty white person. It's very noticeable if I have red. But if we have someone who actually has some melanin, actually has some color, it is sometimes not as obvious. So keep that in mind. We want to make sure they know the medications. Big one. Do not stop taking your antibiotics until you are done or the doctor says you can. Don't stop taking it just because you feel better. How should they apply that warm, moist compress? We don't want to leave it on for hours at a time. We usually want to make sure to not have more than 30 minutes because, again, we might have that risk for skin breakdown or burns. That part needs to be at least 6 inches above the heart. Hand washing, asepsis when we're doing wound care. A big thing is a lot of times we have a really, really infectious wound. MRSA, methicillin-resistant Staphylococcus aureus is a very common one. And so then we're going to do our infection control. So we're like, hey, do not share your dirty, I just wiped up my leg towel with your sister. Make sure you are washing your hands before and after. Make sure you're wearing gloves when you're doing wound care because, again, patients don't always think about these infection control, these safety things. We want to make sure they're inspecting their skin to see if it's getting worse, if it's getting better, if it's changing. Preventative infection measures. Their immune system's already compromised because they're fighting an infection. So we don't want them to be in an area that puts them in high risk for greater infections. Make sure to keep up follow appointments. Make sure they know the symptoms of it getting worse, it turning to sepsis, it not healing properly, if they're having reactions. Because sadly, a lot of times your patients will say, oh, I didn't like the antibiotics, how it made me feel. They stopped taking it. And that's going to be a problem. So, again, lots and lots of education, lots and lots of teaching. All right, next disease we're going to talk about is shingles. Woo! Shingles! So, what is shingles? Shingles is the reactivation of the varicella zoster virus, aka chickenpox. So, any person who's had the chickenpox disease or the chickenpox vaccine can possibly get our shingles in a time of stress or severe issues. The virus reactivates. And this is usually going to happen with a weakened immune system. It usually occurs again with stressness or some sort of illness. They tend to be painful vesicle eruptions, and vesicles are going to be fluid-filled small bumps that kind of pop or ooze when you mess with them, kind of like our mosquito bites. They're going to be clustered. They usually are reported by having tingling, burning, or pain. We're going to have itching around there. We're going to also have fatigue, malaise, and fever, and a lot of times headache. We will also see in their history that they had the chickenpox or they had the chickenpox vaccine. They cannot get shingles if they've never had chickenpox or never had the vaccine. But almost everyone nowadays has had that because we know it's much safer for kids to have the chickenpox than adults. We're not going to be talking about chickenpox itself, but the fun thing is the adults are autoimmune, our immune system tends to overreact with chickenpox, and the symptoms we have is much worse. So we got some lovely pictures here. The shingles will usually follow asymmetrical, so it's only going to be one side of the body, and will usually almost follow nerves. Tends to be incredibly painful. It can be any parts of the body, but we want to be aware of that. Uh, the vesicles are going to originally have clear serous fluid. Eventually, that will change to purulent, thick yellow uh, fluid, and then eventually they'll rupture and crust over. So, our best treatment is going to be treating the symptoms. This is a virus. We can't really fix viruses. We can manage the symptoms. We can give them shingles vaccinations. We usually only do it after they're 50 years old because, again, insurance usually won't cover it before then, and most patients are going to be more likely to have it after they're 50. This will reduce the likelihood or severity of future shingles thing. We can also give them antivirals to slow the progression and lessen the symptoms, but again, it will not fix the problem. And then we can treat the symptoms. We can give them pain meds, corticosteroids, because you can't have an immune reaction if you don't have an immune system. We can also do our NSAIDs to help with pain. Triamcinolone, which is a slightly better than an NSAID. It's going to help with pain management, can be injected into the actual vesicles or underneath them to help alleviate the pain. So again, we want to do physical assessment. We want to figure out what's going on. Is this actually shingles? Has it ever happened before? We want to make sure we're giving them medication and teaching them. We want to know what is their biggest concern. Educate and explain our procedures. Big thing is they're going to be standard precautions unless disseminated. Disseminated is a fancy medical term to say that those vesicles have popped. Once they have popped, or if the patient is immunosuppression, we're going to put them on contact and airborne. So chickenpox and by extension shingles is considered an airborne disease. And that we're going to talk about that a little bit more when we talk about our different kinds of infections. But I know for me, um, back at my day, we had what was called chickenpox parties. And I don't know if anyone listening has had that. And that's where a kid had chickenpox, and everyone in the neighborhood would bring their kids in, put them in the house for 3, 4 hours. Parents would be outside barbecuing, having a good old time. I remember going in, I did not talk to a single child. I was just coloring and playing by myself. And 2 days later, I had chickenpox. But this was a safe and effective way to get everyone sick at the same time, because again, we know it's better. About 5 years after that, they came out with the chickenpox vaccine, and still mad about it. Ugh. But since it is airborne, you do not need to talk to the person. So think about it. We would need to put these patients, once it's disseminated, into an airborne isolation room. We also want to tell them, hey, if you're living with someone else, we can give, shingles can give people chickenpox because it's that mutated form. So we cannot have a nurse or an aide go into that patient's room that's never had chickenpox or chickenpox vaccine. We also don't want pregnant nurses, doctors, or aides taking care of the patient, because even if the mom is protected, the baby is not. So that's a big safety thing, a big RN management thing that you might need to think about. Because another big question they love is, where are we going to place these patients? How are we going to place them? Focus is going to be comfort. They are going to be measurable. Pain, tiredness, fatigue, fever, they just feel like bleh all the time. We're going to monitor for complications. Things such as shingles can sometimes erupt in and around the eye, and there's a risk for permanent blindness. So we're worried about that. We're worried about if they scratch. Now we have an open wound. We're worried about fever and fatigue or underlying illness. Teaching. Once you have shingles, you're more likely to have it again. Anytime they're stressed or they have compromised immune system, it's possible for it to come up. So if they have it, we do want them to get the vaccinations, because that will reduce the likelihood of them having, or if they have it again, it will be less severe. Usually it doesn't take more than a week or two for the symptoms to alleviate, but each patient does have specific changes. Oatmeal baths, calamine lotion to help with itchiness. We don't want them to scratch or rub. Herpes zoster or our shingles usually occurs after 50. It affects Caucasians more frequently than others. So again, our pasty white people. Woo. Our patient teaching, we talked about a lot of these. Make sure they get vaccinations if they haven't yet. Make sure they're taking their medications properly. Make sure they're properly covering those lesions and caring for them. We already have that compromised immune system because they're stressed and or sick, so we don't want them to have cellulitis or infection on top of everything. Proper hand washing. Alternative pain reductions. We don't want to just give you drugs. Diversional activities, relaxation techniques, all of those things can help because pain meds can only take you so far. Rest, avoid scratching, want to avoid someone else. We're like, this is not the time to go visit your 6 month old. All right, not going to happen. And then again, notify the doctor if they're having symptoms of severe problems, complications, anything like that. Right. Last thing we're going to talk about is nail disorders. Nail disorders, the main one we're going to be talking about is going to be our clubbing. So, clubbing is a symptom of prolonged hypoxia. And again, it's a symptom. So, we'll usually see it with our patients with COPD or asthma. Um, and that just tells me that is different than our cyanosis, which is a symptom of acute hypoxia. We want to be able to differentiate. One of the things I learned is what's called the diamond nail test. And you put your two nail beds together, and you should be able to see a diamond or a little window in between them if you look through that. If you do that, that means you have healthy nails. If you have clubbing, that window will not be visible. Most of y'all have been nurses for a hot minute, so usually we can just go in the patient's room, look at it, and be like, you got club. Again, that's just a sign of chronic hypoxia. Most of the nail symptoms or nail disorders we're going to talk about are a symptom of another disease or disorder. So it tells us what's going on. So some vocab, onycholosis is the separation of the nail from the underlying nail bed. And we have this lovely picture right up here on the top. Onychomycosis is going to be a fungal infection of the nail. That's when the nail starts turning yellow, kind of greenish, almost like powdery. Terry's nail is the nail is going to be completely white. It almost looks like a shattered window. And for our Terry's nail, that is usually going to be a symptom of liver disease, heart failure, or diabetes. The Terry's nail by itself is not a problem. It is just a symptom of another disorder, disease. Leukonychia, white spots, vary in size and space. This is usually caused from prolonged trauma, such as them biting on their nails or getting manicures, pedicures all the time. And that can cause that little bit of things. Our boo line, which is the very bottom, is this going to be transfer linear depression? This is showing or proving that at some point the nails stopped growing. This could be because of severe trauma. It could be because they had a condition that they didn't have the resources to go to building their nails, such as they were really sick. Um, Raynaud's disease, again, it by itself is not a problem. It just tells us something else is going on. Pitting is going to be depressions within the nail symptom. Again, it just tells me something else is going on. This can occur with patients with sarcoidosis, alopecia, dermatitis, or even Rader syndrome. Again, it's just telling me something else is going on. And then trauma to nail, that's when the nail starts to, you'll see that little black blue spot slowly move up the nail. I've had it happen before when I accidentally slam my hand inside the door. I wouldn't suggest doing that. Um, Again, it's going to take several weeks for that to go away because the nails grow about 1 millimeter uh, a day. So it's going to take a while, but usually over several weeks, you will see that spot move up and then eventually disappear. So again, nail disorders can occur at any age, elderly or greater risk, just because less mobility, less movement. We do want to keep in mind nails are a really good place to check capillary refill as well as signs of cyanosis or jaundice, especially for patients who have darker skin tone. We want to teach our patients, again, take all the medications as prescribed, proper grooming, especially if they're diabetic. We don't want them to cut their nails. Make sure you're not going to a one-star nail salon. Making sure they're cleaning feet and nails thoroughly with soap and water. You want to be avoidant of athlete's foot or fungal infections, so not using public facilities. Eat healthy, well-balanced diet, making sure they're wearing correct footwear so we don't have that rubbing and scratching against their follow-up appointments, notify doctor if something goes wrong. And everyone's favorite now, we have our nursing diagnoses. They kind of talked about this before, and this is all those conditions. So again, I want you to take a moment, pause, and figure out what order you would prioritize these with. Okay. So I'm going to go with 1, 2, 3, 4. So we got 1 because that's physiological. We got impaired skin integrity, which is safety. Disturbed body image is going to be our self-esteem. And then risk for infection, because risk for is almost always the least important. All right. So last thing, we got this lovely NCLEX question. So I want you to pause and answer the best of your ability. And we're going to have one from option 1, one from option 2, one for 3, and one for 4. So pause. Let's see how you did. So, avoid sun exposure. Nurse explains the most effective way to reduce the risk of skin cancer is to avoid sun exposure. When teacher proper sunscreen use, the nurse instructs the client to select a product that has an SPF at least 30 and broad spectrum coverage. Nurse teaches the client to monitor skin lesions using the ABCDE method. To further reduce risk, the nurse recommends the client exfoliate the skin weekly. All right, that is everything.